Okay, so I can see that everyone is getting logged on now. So I will just begin by welcoming everyone to the Division of Rheumatology Grand Rounds. I just want to have set a few reminders before we get started. Dr. Katz will be saving about 10 to 15 minutes at the end of her lecture for questions. So rather than answering them throughout, we will save that for the end. If you have any questions for Dr. Katz, please type them into the Q&A box that you'll see at the bottom of your screen, as opposed to the chat. That'll just keep them concentrated in one place. And now I will pass things off to Dr. Katie Weisham. Thank you.
All right, thanks all. Good morning. It's my great pleasure to introduce our Grand Round speaker today, Dr. Patricia Katz. Dr. Katz received her PhD in educational research from the University of South Carolina and has been working at UCSF for the last 30 years, where she's a professor of medicine and health policy in the Department of Medicine. Her research has focused primarily on RA and lupus outcomes and has a large focus on disability, having created the Valued Life Activities Disability Scale, which broadened the evaluation of disability to include more meaningful life activities. Her research is also focused heavily on patient-reported outcomes, and she is responsible for moving many measures such as the Nih Promise score into mainstream rheumatology research. Lastly, she's conducted important studies evaluating the complex interplay between socio-demographic characteristics and health outcomes. These efforts have resulted in over 250 publications. In addition to being a prolific researcher, Dr. Katz has been recognized for her skills as a mentor. She's successfully mentored over 50 postdoctoral fellows and junior faculty, and she was recognized for her mentoring track record by the ACR in 2019, receiving the Excellence in Investigative Mentoring Award. Her other accolades include ACR Professionals Master, AHRP Lifetime Achievement Award, and Presidential Award. She's currently the editor of ACR Open Journal and serves as a member of the ACR RRF Scientific Advisory Council and the NIH NAME Study Section. Today, she will be discussing patient-reported outcomes and how to implement them into clinical research. Dr. Katz, thank you for taking the time to speak with us, and I will hand it off to you now.
Thank you, Katie, so much. Can you hear me okay? I'm assuming
we can hear you, Patty.
Okay, good. So I want to thank you very much for that kind invitation, and also for inviting me to speak to you. I do wish I could be there in person. It's always a little odd just doing this by Zoom and speaking into my computer, but that I think we're all becoming a little more comfortable with that these days. So today I'm going to talk about incorporating patients' perspective into research. There are multiple ways to do that, but today I'm going to focus on, what's going on? There we go, self-report, or as we have come to refer to it, patient-reported outcomes. So why do we care about patient-reported outcomes? The main reason is that it can provide us with information that really has no other source. There are some things that only patients can tell us. Well, we might make assumptions from clinical assessments. I'm sure you've all had patients whose clinical presentation might appear mild, but who report significant levels of pain or fatigue or a significant impact on their function. And vice versa, the patient who appears to have significant radiographic disease, but who still maintains a very active life with few functional impairments. Rheumatology has always been at the forefront of collecting patient input from patients in a systematic way, what we know as patient-reported outcomes. This came from a recognition that the impact of chronic conditions such as rheumatoid arthritis or a total picture of health status couldn't be captured by biologic or physical measurements such as SED rate or radiographs alone. The focus on patient-reported outcomes grew out of efforts to define and measure healthcare quality. Over 50 years ago, in the late 1960s, Avis Donabedian proposed a model of healthcare quality that was later expanded by the Institute of Medicine. And in this model, you can see there are three major components: structural measures, which include, hospital facilities, physician mix, equipment, and other kinds of resources. Structure was proposed to affect outcomes directly, but also through processes of care. So processes are the things that actually happen in a clinical encounter. It could be a clinical process, such as the types of services provided or the appropriateness or timeliness of the care. Many of you are probably familiar with these with some of these process measures of quality, because the ACR has been very active in promoting these kinds of quality measures. And they include things like are immunizations provided appropriately, or are medications prescribed according to guidelines. Process measures also include the quality of the patient-provider interaction. So it could be appropriate communication, timeliness, or cultural sensitivity of care. And then the final component of the quality model was outcomes, or measures of the effect of healthcare on the health status of patients and satisfaction. So initially, when people were thinking about the outcomes of healthcare, focused really on morbidity and mortality, or the things I have highlighted here: death, adverse events, readmissions, and resource use. But with this new model, outcomes were expanded to really include things that required the patient's input: satisfaction with care, quality of life, and ability to function in daily activities. Overall, these outcomes came to be known as the 5 Ds. So we have death, disease, disability, discomfort, and dissatisfaction.
Patty, can I interrupt you briefly?
Yes.
I think there may be a paper or something near your microphone. So
okay, I think it's my jacket. So let me see.
I apologize.
No, it's okay. Thank you for pointing that out.
Thank you.
So from a rheumatology perspective, in the early 80s, Jim Fries from Stanford came into the picture to develop the HAQ, the Health Assessment Questionnaire. And you're probably all familiar with some form of the HAQ. The HAQ was intended to actually measure a slight variation of the 5 Ds. He inserted drug toxicity and dollar cost, which is not here, it's over here. So he changed it slightly, but the HAQ was originally intended to be used across all conditions, so that you could compare the effects of different diseases. But eventually we ended up with the remainder of these items. All of these things down here are really not used anymore. And we have here the first PRO in rheumatology, or the HAQ. So I want to talk a little bit more about the HAQ because it's going to come up several times in the talk. And some of you have probably never actually calculated a HAQ score, so I want to walk through that. So the HAQ has 8 domains: dressing and grooming, arising, eating, hygiene, walking, reaching, gripping, and activities. And there are a total of 20 items that fall within these domains. So when a person fills out a HAQ form, they rate each item on a difficulty scale of 0 for no difficulty to a 3, which is unable. And then each domain is then scored. So the score for the domain is the highest level of difficulty within that domain, not the average of the scores, so of the item scores. So if you say you have no difficulty dressing yourself, but you have great difficulty, which will be a 2, shampooing your hair, the score for dressing and grooming domain is a 2, not a 1. It's not the average, it's a 2. So, and then to make it even more complicated, there are a series of questions, excuse me, that ask about use of aids or assistance. So, for example, if you say you have no difficulty walking outdoors on flat ground, or no difficulty climbing up 5 stairs, but you use a cane, then both of those items are immediately upgraded to, I don't know if upgrade is the right word, but changed to a score of 2 because you're using an aid. So then after all of that, you get the average of each of the domain scores, and you end up with a total score of somewhere between 0 to 3. So that's the hack. And there are a lot of good things, positive aspects to the hack. The first is that it's really the first widely used measure of functioning and patient-reported outcome in rheumatology. It's been in use since 1980, so there's a lot of history using it. If in longitudinal studies, sometimes people can have years and years and years of hacks, so you can do things like look at trends in functioning in rheumatoid arthritis over time, and how the introduction of new medications might change that. It also provided a systematic and standardized way to quantify functioning in both research and clinical settings, and it's been used in clinical trials. Either the original hack or one of its modifications are used in most rheumatic diseases. There have been modifications, for example, for scleroderma, there have been, and other conditions, to make it a little more tailored to that specific condition. And then the hack is really widely and easily available. It's been translated and culturally adapted into over 60 languages, and it is free, unlike some of the other widely used outcomes measures. But there are some serious limitations to the hack. And the first is that it really covers a limited range of difficulty, both in terms of its functions and the activities that are covered. So if we consider the full range of function, we consider things that are easy to things that are hard, all of the items on the hack are really pretty far down on the easy end. This is probably a function of when the hack was developed in the 1980s. And so while this might have been appropriate in the 1980s for where rheumatoid arthritis prognosis was and the treatments that were available, it's much different now. So with the advent of newer and better therapeutics in RA, for RA and other conditions, people's goals are no longer just being able to get on and off the toilet or stand up from a chair without assistance. They really want to engage in all aspects of life. And you see this in the ads for drugs that we all see on TV. It seems like every other ad is for a biologic for some condition or another. And so people really want to engage in this broad spectrum of life. And those areas are not included in the hack. It's really beyond. Many of these are, they're both qualitatively different and in many cases farther up that spectrum of difficulty. So this also leads to the second problem with the hack that I want to mention. And that is that we have a really high number of people who score a 0. And this is a distribution from a large frequency distribution of hack scores from a large group of people with rheumatoid arthritis. And you see there's a big clump of people down here at the lowest score, which in psychometric terms is called the floor. And while that's really good for people with RA, that they're not having limitations in their function, it's really not so good if you're trying to study an intervention and you want to see its effect on function. Someone who's already at the floor or has the lowest score can't get any better here. Some of the modifications of the hack have attempted to address this issue. The MD hack added 2 questions dealing with walking 2 miles or participating in recreational activities, but it still has a non-normal distribution and it still has a lot of 0 scores. The hack 2 was a later modification, and you can see a distribution of it here. I mean, it looks a little more normal with the distribution, but there's still this big clump of 0s here. So it's more sensitive to change, but it still has that significant floor effect that can affect its sensitivity to change. So another downside of the hack is that people are really penalized for adaptation. So in some sense, this is a theoretical question. I mean, do you want to measure capability? In which case you might want to include these kinds of penalties for adaptation, or are you trying to measure someone's actual ability to function, in which case you wouldn't? Like I said, it's a theoretical question, but there's some food for thought there. So since the introduction of the HAP, there have been many PROs introduced in rheumatology, and there have also been many advances in measurement science. One of the most transformative PRO efforts was the introduction of the Nih Promise Measures. Development of Promise was a huge effort that was supported by the Nih Common Fund. Promise was envisioned as a suite of measures that would revolutionize the measurement of patient-centered outcomes. They would be developed using state-of-the-art psychometric methods. They could be used across health conditions, across age groups, and the results would then be standardized to population-based norms so you could compare over different conditions. The Promise has a theoretical model. It's based on the World Health Organization's model of quality of life. You can see here that it has 3 major domains: physical health, mental health, and social health. The primary domains are these that are in the darker colors. And in physical health, you'll see that these are things that we measure quite frequently in rheumatology: physical function, pain intensity, pain interference, and fatigue. Mental health issues are often measured quite often. We don't focus so much on social health in rheumatology. And then there are all these other domains that have been added. Domains are still being added as people go through the process of qualifying measures. They have to go through a certain process to do that. But then once they do, then they're available for use. So some of the advantages of the Promise measures are that they are applicable across conditions. There are pediatric and adult scales. They have these special domains added. Promise measures are available in multiple languages. And some of them, there are fixed questionnaires that are available in 40, 50 languages. And one of the most unique aspects of Promise measures, though, is that they were developed and normed using item response theory. So I know you're wondering, what is item response theory? IRT came into use back in the 1980s in educational testing. It was a major part of my doctoral program. And I'm sure most of you have taken quite a number of standardized tests, the SAT or the MCAT, and those were developed using IRT. So you have experienced IRT even if you didn't know it. So IRT is based on the underlying idea that the items measuring a given construct can be ordered from easy to difficult. And it's easier, I think, to think about this initially if we're thinking about math. So we have items that are arrayed on this continuum here, and the easy items might be, simple addition, and you move up through here, and maybe you go through division, and then you get up to trigonometry or algebra, or then up here calculus, and then beyond calculus. I'm not sure what's out there, but I know there are things. People can be arrayed on that same dimension based on their abilities or knowledge, or which would be measured by their responses to these items. So items measuring constructs such as function can also be arrayed in the similar fashion. And people can be arrayed based on their functional status. So we might have easy items such as just walking to get around. We have more difficult items that might be, being able to shop or run errands. And then at the very hard end, you would have participation in athletic events. So when people are developing measures using IRT, Items are developed that are intended to cover the range of difficulty from easy to hard. Then these items are quote unquote calibrated, which means their difficulty is established. And there's a whole mathematical process to doing that, which I'm not going to go into here because it's going way down the rabbit hole. Those items then with their are combined into item banks or large sets of items, and they have a known established difficulty parameters. So what are the advantages of IRT? First of all, items and scales are intended to be invariant across populations. What that means is that different people can respond to the same items and the same tests, and their results are assumed to be equivalent. There are specific methods in IRT called tests of differential item functioning to test whether the patterns of responses to individual items are indeed consistent across groups. For instance, if they're consistent across educational levels or sex or race ethnicity. IRT also allows the development of computer adaptive tests. So how that works is if you assume that you can rate item difficulty on a scale of 0 to 1, which isn't really the case, but we're going to go that way for simplicity. On a computer adaptive test, a person would come in at an item at the midpoint. If they fail that item, or in the case of function, if they were unable to do whatever this item was, then the computer would serve them up a much easier item. If they pass that item, or they were able to do that particular action, then the computer is going to sequentially give items that are harder. If they fail that one, then it'll go back to an easier item until it can hone in on where a person's responses place them on this continuum of function. So because of that, when a cat is used, all of the versions of cat are potentially different. The advantage of a cat is that it can be somewhat personalized, which means it might be more precise. And there actually are a number of studies in rheumatology that have used cat versions of the Promise measures. IRT, because we have this, these established item difficulty parameters, can be used to create a number of short forms, which is in Promise language, what you would think of as just a regular questionnaire. So paper, short form, short number of static number of questions. And the short forms are created by selecting a range of items of varying difficulty that can, and the scores on those short items are, because we know the difficulty, the scores should be equivalent to what you get from a computer adaptive test. And the different short forms should lead to equivalent scores if a person took all of them. So whether it's a 4-item short form or a 10-item short form or an 8-item or a computer adaptive test, a person should end up at roughly the same score regardless of which version they use. Promise scores can be converted to T-scores, which have an average of 50. And these are based on population norms and a standard deviation of 10, which is represented by these dotted lines here. And this is the kind of output that you see from the cat version, which is, I think, nice and colorful, and it actually is pretty clear to interpret. So here you can see our depression and anxiety scores are pretty close to the population mean. Sleep disturbance is a little higher. Fatigue is between like 3/4 of standard deviation higher, and I think this is from an RA study. And then pain interference was more than 1 standard deviation worse than the population mean. Promise scores higher scores represent more of whatever it is you're measuring. So if you're measuring a negative construct such as pain or fatigue, then higher scores are worse. If you're measuring something positive like physical functioning, then higher scores are better. So here again, this is from the same RA study. You can see that physical function was below the population mean by about a standard deviation, and social functioning was also worse. As I mentioned, promise measures have become have been established in many rheumatic conditions. Actually, Jim Fries, who worked on the hack, was very much involved in creating the physical function promise measure. So we have deep roots there as well. They have studies have used both the cat versions and the short versions, and they've been validated against some of our legacy measures, such as hack or the SF-36. There have been crosswalks developed that allow you to convert promise scores and physical function to a hack equivalent, and the reverse. And so there are a lot of really positive things about the hack. But at the same time, there are still some limitations. First of all, these measures are generic. So if you are specifically interested in disease-specific content, for example, joint symptoms or skin issues that might be specific to a disease, it's not there. It may not be there. They may be added eventually, but right now they're not there. And the other is that with the short forms, we are still seeing some floor and ceiling effects. That may or may not happen with the cat versions. I don't think that anybody's really looked into that. And so, for instance, in some of my studies, we're seeing significant floor or ceiling issues, but it's difficult to know if that's because we have a population that's somehow biased towards people who are less sick. Anyway, it requires some additional work. Since the introduction of the hack, there have been literally hundreds of outcome measures introduced. Some are disease specific, others are generic, and they can be applied to different populations. So how does one go about evaluating and choosing PROs? So the first issue to consider is content. What do you want to measure? And what group or groups do you eventually want to compare the results to? For something like function or fatigue, you could consider a generic measure like one of the promise measures. There are also some, disease-specific measures, and that for fatigue or function. For instance, there's an RA-specific fatigue measure. I don't know how much it's used, but it has been made. In other situations, you might be more interested in a disease-specific measures, for instance, for disease activity or disease-specific symptoms. Next, you want to consider reliability and validity. So there are a number of different measures of reliability. Basically, reliability is looking at consistency. So it might be consistency across raters. It might be consistency over time. That would be test retest reliability, or it might be looking at the consistency of within a scale. So are the items within a scale measuring the same construct? There are also a number of different kinds of validity, but basically validity is an expression of how well a measure actually is measuring what you intend it to measure. So this is sort of a classic illustration of the relationship between reliability and validity. So this first one here, this is a fairly precise measure. It's all of the items are targeting the same point. But if you consider that your content is this whole target, and this center part is what you're really especially interested in, this is reliable, but it's not really valid because it's not measuring your content very well. This measure might be considered to be valid, although it's spread out pretty widely, but it's certainly not reliable because it's not very precise. Here, this is neither reliable nor valid because it's not measuring the whole domain, and it certainly is all spread out. And this last target is what you really want to find, something that has items measuring directed in the specific area that you're interested in, and all measuring the same concept. Okay, fine. Okay, so responsiveness to change is also important. I mentioned this earlier as one of the problems with the hack. You want to be able to detect differences over time in response to a treatment or an intervention. And you want to know if there's no change, that it's really, if you don't see a change, you want to know it's because there really is no change and not because you have a bad measuring tool. There are also some considerations of psychometric properties that are useful for interpretation. The first is a minimal important difference, which is also referred to as the minimal clinically important difference or the minimal important change. And that started off with the term MCID, minimal clinically important difference, because it was really based on what was seen as a clinically important difference, not necessarily from the patient's perspective. It's the terminology and the calculation of those has changed, so that it's really based on what patients perceive as an actual difference or change in their state. So here in this illustration, you can see that going from here to here it's a change, but it's not really enough for a patient to perceive that there's a real difference. But if a patient changed from here to here, this is an illustration of what an MID or an MCID might do. So they're actually doing better. So it's a measure of doing better. I mean, you can also have the reverse, which is what is doing worse. We like to think about this more though. And then there's this new concept, it's not that new anymore, but it's newer than the others, called the patient acceptable symptom state. And if you think of an MID as doing better, the past standard is doing well. And to put this in terms that you may be more used to thinking about, it's like the equivalent of remission or low disease activity. So it's basically at what standard, what score, what level the symptoms have to be before patients consider that it's okay, that they'd be happy being there. And there are methods established for calculating both of these. We've done some work looking at both the MID and PASS for some of the PROMIS scales in lupus, and we found that overall the MID for most of the scales was between 2 and 3 points, which is pretty consistent with what people have seen in other conditions. So it's nice to see that replication. We also looked at the PASS estimates. And so the interesting thing here, remember that the mean score for the PROMIS measures is 50, population mean. So in each case, you see what patients were assuming would be where they wanted to be, which is think of it as what people aspire to, or what they would be, where they would be happy if they met that level. It's all considerably better than the population mean. So here for physical function, it's about a little more than a half a standard deviation better than the population mean. Fatigue is lower. And social functioning in particular, people wanted to be considerably above the population mean. So the take-home message is that people are not aspiring to be at that average level. They want to be better than that, which goes back to sort of underscores the issue, one of the limitations of the hack. But there's also something else to think about, and that is what's the baseline level. So here, this is another MID, minimal important difference for worsening and improvement, and another PROMIS scale, and this is an RA cohort. And so we saw that the minimally important difference for worsening and improvement was roughly 2 points in both directions when we looked at the whole group. But if you look at baseline pain level, there were big differences. So if people started off low, for them to be worse, they wanted to, it needed to be a bigger difference. They didn't really envision themselves getting much better. And if you looked at the people with high baseline pain, It was exactly the reverse. So to get better, they wanted to see an actual, fairly large change, about, roughly a half a standard deviation improvements. And they didn't really envision themselves getting much worse. And we see the same, the people in the middle were pretty close to the average. We saw the same thing for PASS levels. So looking at this, if we look at baseline pain, so people who had low pain were roughly at the population mean. They wanted to be almost a full standard deviation below before they would consider themselves to be good. And in both of these other cases, people were aspiring to lower levels, but they were still higher than this low baseline pain measure. So to keep people from having to spend hours and hours and hours searching around for the best measures to use, in 2011, the ARHP commissioned a special issue of Arthritis Care and Research that reviewed outcome measures used in rheumatology, which I edited. That issue had over 35 topic areas. It had disease-specific measures for a range of conditions, including RA and lupus, gout, scleroderma, ankylosing spondylitis. It included measures of function, both overall and then for specific anatomic areas such as hip or hand, knee, spine, feet. There were quality of life domains for function, disability, pain, fatigue, and sleep. And then it included measures of psychological and social functioning, such as depression, anxiety, and self-efficacy. Articles from this issue are still, almost 10 years later, among the most frequently downloaded ACNR articles, which shows the high uptake and use of PROs in rheumatology, and it continues to grow. So to address the burgeoning field of PROs, ACNR will be publishing a new edition of this special issue this month. It should hit your inbox in days. It was intended to come out right before the annual meeting, and I think we're there. So I was honored to edit this one as well. It's even larger, and the topic areas have been selected a little differently. So just quickly, I'll show you the domains here. We have disease-specific measures for all of these different conditions. Some of these have been added. We have measures of symptoms. We have measures of quality of life for both adults and pediatrics. We've added physical activity because I'm the editor and I got to add some things I was interested in. Plus, I think there's more and more research in this area. And then there's a range of psychological and cognitive domains covered as well. Depression and anxiety were there before, but we've added stress, the patient experience of care, and then review of cognitive function measures. There were in the previous version, and there are in this version as well, fairly detailed, structured reviews of measures, but there are also these nice summary tables at the end, so you can sort of take a quick look at, the content areas, then so you can see what you might want to look at more in detail, and then some summaries of the psychometric properties. So I want to just touch on a few challenges in using PROs. Let me check my time. Okay, I need to speak faster. So there are cultural and language issues. Your patient populations are in Seattle are going to be as diverse as ours are in San Francisco. PROs can be influenced by cultural and language issues. Some groups may have difficulty with numeric rating scales, for example. So questionnaires need to not just be validated in the languages you need to make sure that it's been culturally validated, because some concepts or wording choices don't necessarily carry the same meaning across languages. Health literacy is another issue. We found significant differences in PROMIS and other PRO scores by health literacy, even after adjusting for things you might think would account for the differences, specifically education and income. And just a quick look at this is an example, a paper from our lupus cohort. You can see that on every single measure, there were the people with limited health literacy had significantly worse scores even after controlling for all of these other issues. So whether that is a reflection of worse health status, which is possible because people with limited literacy may not be as good at taking care of themselves or following medical directions, or whether it's a measurement issue, at this point, we really don't know, but it's, again, it's something to think about. And then there are issues on mode of administration. So there's interviewer administered versus paper. On an interviewer administration, people may be less comfortable expressing dissatisfaction or talking about sensitive issues. But the advantage of interviewer administration is that you don't have as much missing data. And if there's a question, sometimes the interviewer can answer it, so the person will actually answer the question as opposed to skipping it. Paper versus online, we really don't know too much about that at this point. The one time I've looked at that, people had a choice of answering questions online versus on paper. And what we found was that there were some differences, but the biggest difference was age. So it might have been comfort with using the computer versus not. There were the associations of scores with other variables were the same, but there was a consistent difference overall. So to revisit the issue of why we use PROs, as I've already mentioned, there's some information that can only be collected from patients. The second is that patients may have very different views of their health and well-being than providers. And just here's an example, the correlation of PROMIS scale scores with a physician-reported SLEDAI in a group of lupus patients, it is literally 0. So patients may be considering different things when they're rating their health or when they're evaluating their health. And it's understandable if they're evaluating different things, that there's no relationship, but that discordance may also have a negative impact on patient-provider communication. Patients may feel that they're not being heard, or their symptoms are being discounted or not addressed. And ultimately, that might lead to poor adherence to treatment because they feel like their physician isn't hearing them. And poor adherence to treatment might lead to poor health outcomes. So it is important that we have at least some recognition of these differences. And then finally, PROs can increase the engagement of patients in the process of care. So now many people are administering PROs in a clinical setting, for example, to meet quality reporting guidelines for RA. But patients may wonder what's happening to those PROs if the treatment team doesn't actually talk to them about what's happening and how they might be changing. So this has led to some work on the best way to integrate PRO measurement into PRO measurement and tracking into clinical care. And just as an example, this is a draft dashboard that Gabby Schmayuk and her team at UCSF have been working on to integrate into RA care. And they had a lot of patient input on this, on how to design the score presentation and the green areas, which reflect what's good. Patients were really wanted to have their labs here. So this is work that's ongoing, but it's an example of how PROs might be used in a clinical setting. So I'm going to stop there since I think I am at my limit. And I want to thank you for your attention, and would love to hear some questions or thoughts from you.
Thanks, Patty, for that great overview. We have a couple questions, and I also have a couple questions. So let's first do from the Q&A. What are good resources to use for someone who would like an introductory primer to PROMIS measures for different domains? And what advice do you have for someone who might be interested in collecting PROs for a registry or a prospective cohort, but they have limited formal training in this regard?
So if you go to the Promise website, which is no longer called Promise, I think it's called healthassessment.net, they have a good bit of material there, which can give you a good overview. You can explore what kinds of measures are available. There are short forms for most of them. There's short forms for all of them. Interestingly, the cats can only be administered at this point in English and Spanish. So if you wanted to go that direction, I know you also probably have a high proportion of patients who speak Asian languages. So, that's not an option. So for Promise, I would actually go to their website. Katie, what was the second part of that question?
Yes, and what advice do you have for someone who might be interested in collecting PROs for registry, but they don't have formal training?
So I think that I would go back, and you'll be able to refer to the new issue of the ACNR outcomes measurement issue. So that would be a good resource for starters. I would first of all focus on, as I said, the content. What are the things that you think are important to measure? There are other things to consider, like how much time can people actually invest in completing those? And so you may have to make some trade-offs. It's sort of a balancing act in that way. But content is the first thing. Length is after you identify measures that meet your psychometric criteria, then you have to balance issues of length. If you don't have much experience in using them, there are, I'm sure you can administer them, you can score them, you can interpret them, I think without a lot of expertise. And again, the special issue, which I'm assuming you're all members of ACR, so you should be getting that. We'll have some information about that. So that's going to be a good resource. If you have specific questions, you can always shoot me an email and I will either try to help you or can direct you with somebody.
Thanks, Patty. Less of a question, but more of a point. Someone was just commenting that I wonder if how COVID has impacted these measures. And there was a comment that they're now incorporating Promise measures into studies of COVID. So do you have any thoughts on that?
Yeah, we administered a couple of COVID specific questionnaires since we weren't able to actually bring people into visits for a while. And we did see that there were some changes in scores. We saw that there were high levels of stress. And stress is associated with negative outcomes in many of the things that we were interested in. Even disease activity. So the advantage of these is that they can be administered. I know people are using REDCap or Qualtrics or other online administrations. We do them by telephone interview as well. So all that can be done remotely.
Thank you. One question I have is, what do you think the biggest item that we miss in our clinical practice as we take care of patients? Things that our measures just really overlook. I know you're interested in sleep and fatigue. I don't know that we query that very well.
Sleep and fatigue, I think, fatigue is sort of a standard question that if you're going to go beyond pain and function, that would probably be the next one. Sleep is important, but if you can remember that slide I showed about the PASS scores for the different domains, social functioning, I think, is something that's really important to people. So how well are you able to do the things you want to do with your family and friends? I think that's something that's probably overlooked.
And then what we do about that as providers is,
what do you do about that? That's always the problem, isn't it? Is the problem because of the disease? Is it because of the medications, or is it something that's totally unrelated to the healthcare system? I mean, there's always that tension, right?
Right. Another question coming in, what is your sense of the best Promise measures to use in clinical practice, not a research study for lupus?
For lupus, I can tell you, if I were making the choice, I would do the physical function, the pain interference, fatigue, sleep disturbance, and one of the social functioning measures. And then I would, depending on how much time, space, and you have, I would probably look at depression and anxiety.
And how much time do you think that's going to put someone in clinically to go through?
If you're doing there are actually these promise forms called profiles, and they include 4-item short forms for 7 domains, which are pretty much the ones I just listed. And so there's a 29-item one that should take people, I don't know, 5 minutes. I mean, they're short items.
Great.
So,
sorry, did you have more on that?
no, I was just saying it can be done pretty easily, pretty quickly.
Another question I have is, where do you see the PROs going as we move more digital? Have there been good efforts to make mobile applications of Promise? Are there other things that you're kind of incorporating into your research?
We're not using too much in terms of mobile applications, but that's certainly being done. I think Jeff Curtis's group at UAB has been working on that probably more than anybody else. There are a lot of online versions using REDCap, and the CAT requires some sort of digital administration, and people have been doing it on iPads. You can give people a link and they can do it from home. Mobile requires a little more new programming, but like I said, I think Jeff Curtis's group is working on that. And I'm assuming once it's up and running, it'll be fairly available.
Great. I don't have any other questions from the group. Any other last questions, please type them in. If there aren't anything else, I just want to thank you, Patti, so much for your time. This was a great overview to hear kind of where this all came from and where we're going. Kind of makes us all have to think more about how do we incorporate these in clinical practice? Because I think the point that you make of engaging patients in their care is really important. We can tell them all the things we think, but if it doesn't matter to them, it doesn't matter. So this is great.
Well, thank you very much. I wish I could be there and see all your faces. But maybe after COVID or next year, maybe things will change. So I hope to see you all in person sometime soon. Thank you for asking me.
All right. Thank you so much.